This is a short preview of the lecture video on the topic Fetal Growth Restriction Guidelines 2020, which involves the definitions of small for gestational age, fetal growth restriction, and discuss in detail the guidelines, ISUOG guidelines, and Society of Maternal Fetal Medicine guidelines, which have been published in the year 2020. This is only a short preview of the lecture, which runs for about 45 minutes. The short parts of the various parts of the lecture video will follow. Having gone through the preview, if you wish to listen to the main lecture video, go to sonoshare.in, growth endocrine diseases, and worst outcomes in FGR is seen in when the estimated fetal weight is less than third percentile, associated with fetal doppler abnormality. Circumference is less than 10th percentile for the gestational age. And this small for gestational age alone, there is no increased risk of morbidity and mortality. Whereas fetal growth restrictions derived. So when weight percentile is derived, when you plotted on the growth, we know if it is less than 10th percentile, then it qualifies for small for gestational age. So all this put together, there is an error of about 18% in the derivation of estimated fetal weight in the antenatal scan. So the imprecision, one case scenario I am putting forth here. The crown rump length has been done, and according to that, at 10 weeks. So then a repeat scan after an interval of, at 30 weeks is taken, and the interval growth, estimated fetal weight is 1000 grams, which is less than 10th percentile for 30 weeks. So we diagnose SG. Increased risk of adverse perinatal income. So this is the classical definition of FGR, or it can be it can be not only SGA, it can be SGA, AGA, or LGA plus increased risk of adverse perinatal income. Then no screening for toxoplasmosis rubella or herpes is advised. But if the couple with FGR diagnosis elect diagnostic testing with amniocentesis, then they can be counseled for PCR for CMV. Now, tools for in FGR, the steps are diagnosis, surveillance, and management, and the tools are color Doppler, growth velocity, artery shows absent in diastolic flow, and or AC or estimated fetal weight less than 10th percentile, along with one of these two, that is uterine artery more than 95th percentile and or umbilical artery more than 95th percentile. So this is the diagnostic criteria by Delphi consensus in the ISUOG guidelines for early onset FGR. Now, late onset FGR or term FGR, the diagnosis is the gestation age is more than 32 weeks, no fetal anomalies, AC or estimated fetal weight less than third percentile, or 2 out of the following 3 criteria, that is AC estimated fetal weight less than 30th percentile, drop in growth velocity of more than 2 quartiles, or umbilical artery more than 95th percentile, or CPR less than 5th percentile. So this is the criteria by Delphi consensus for late onset FGR. Now, late FGR diagnosis in the another step in the diagnosis of late FGR is if first trimester preeclampsia screening was normal and anomaly scan is normal with a normal estimated fetal weight or AC, Then screening growth scan is done at 36 weeks, so that the pickup of diagnosis of late onset FGR is better. Now, the difference between early and late onset FGR, or in early onset FGR, the problem is management. Diagnosis is better, but management is the problem. Whereas late onset FGR, the problem is diagnosis, and the management is easy because it is near the term. The major difference is the hypoxia. So because hypoxia is there for a prolonged time in early onset, the tolerance to hypoxia is there in early onset, but there is low tolerance to hypoxia in late onset FGR. Now, management of FGR, there are no preventative strategies or treatments for FGR that have been proven to be effective. This is according to SMFM. After 26 weeks of gestational age, and after that each day of prolongation improves by 2%, and generally the consensus is the delivery can happen 32 weeks after administration of steroids. So this is the aim. Now, monitoring less than 32 weeks in early physical profile, then every 12 hours monitoring is done. So this is the surveillance protocol that can be followed. Once the lung maturity, that is 32 weeks, is reached 85th percentile. So these are the trigger criteria for delivery. Also above 36 weeks, estimated fetal weight less than third percentile. Now above 38 and 39 weeks. If there are no contraindications, labor induction can be done, and during labor, continuous fetal heart monitoring. So, the SMFM guideline was developed based on many considerations, taking into account the training available for the professionals involved in management, and ultrasound and CCTG resources available. So taking this into consideration, their definition is and management is